Good morning and welcome to the work session on House Bill 619. This is a work session and not a hearing, so we will be working as a committee. However, we may at times choose to call on somebody to provide some information from those who are here. I expect that there are far more people watching either live or the replay of this than are here in this room, so welcome. House Bill 619 has a number of different sections. Let me make sure I'm close to the microphone. This bill deals with both medical issues, school issues, and conversion therapy. So if we can sort of walk through this bill, the first section of medical begins with legislative findings on the top of page 1. So it goes through with legislative findings that speak to a lot of the background information and continues through the end of page 2 for a system of gender dysphoria care for minors. There is section 135-G1, which provides definitions. That is the top of page 4. On page 6, line 7, there is the section 135-G:2, which is the prohibition of gender transition care for children and young adults. Lower on that page, line 30, is 135-G:3, which is a prohibition on use of public funds for gender transition care. Turning to page 7, line 5, 135G, which is enforcement. Same page, line 26, there is 135-G, insurance coverage. The first is a mandate of no coverage. The second is a non-mandate that says that no organization shall be required to provide coverage. Then at line 33 on page 7 is when it moves to the second section, which is the public schools. There's legislative findings that begin there and move towards the bottom of page 8, where there is a new subdivision in the education laws regarding sex and gender in public school. They're all within 193:41 that would add 3 different sections, one about both enrollment and teaching issues. There's a lot packed into that one single section. Then in Roman 2, there's one about gender segregated activities. That's on line 15. Line 22 is Roman 3, which is about restroom separation. And then line 24 is where there's the violation section. And moving to line 33, there is the final section, which is conversion therapy. Conversion therapy, when somebody is coerced to do something against their will, is just absolutely terrible. The problem is that our language of our law is a little bit confusing, which is unfortunate. So my intention today is that we look through this section by section and figure out where there's an opportunity for conceptual agreement. And when we know where there may be some conceptual agreement on working towards a solution, then take a break. I was thinking it'd be lunch, but maybe we'll take 10 or 15 minutes just to be able to gather our thoughts and any materials. In any areas where we have an agreement to work towards an agreement in that section, we will then come back and talk about those sections and figure out where we can find agreement.
Okay.
Does that work for you?
That works for me.
Okay.
Yes.
Fantastic. So a lot of this there's guidelines, and there's a lot of discussion about leaving the practice of medicine solely to medical professionals. Unfortunately, sometimes in the past that has not worked well. There was a time when not only did doctors call some people undesirables, they also sterilized undesirables. That was practice of medicine, but not something that should have ever been allowed by civilization. And in that situation, legislation to prohibit calling people undesirables and to prohibit their sterilization would have been appropriate. There was also the issue of lobotomies that were done routinely to people that should never have had them, and far too loose usage of electroshock therapy. That actually still is in practice for some things. In severe treatment-resistant depression, that is the 14th, I believe it's around the 14th line now. And I honestly commend anybody who goes through 14 lines of treatment for their resistant depression, because they're fighters who are holding on. So sometimes the medical profession has not gotten things right. Back in the Tuskegee Project, they denied antibiotic treatment to Black men who had syphilis to see what happened in the community and the natural history of that. That was ended in 1972 in the United States, but continued through the 90s in Costa Rica. And that was endorsed by the American Medical Association at the time, and it was only apologized for 2 years ago. So while doctors and medical societies often get things right, there are some times when it is appropriate to step in. So the question here is, if there are some areas where we look to guidelines, we figure out where there's already agreement and guidelines, and just say, in the state of New Hampshire, we are going to set this floor on requirements for care. That is actually being done. The conversion therapy ban is legislation that could be considered to interfere in the practice of medicine. And I think that maybe that might be the first one that we could talk about. There are two organizations where I've turned to guidelines. The WPATH, the World Practitioner Association, provider?
World Professional Association for Transgender Health.
Yes, World Professional. I apologize. I was getting the P section wrong. They have a new standard of care 8 that recently came out and is very comprehensive. There's also the Endocrine Society, who's dealt with hormones and other endocrines and endocrine disruptors for a very long time. So I personally look to them towards more of the hormone treatment. The WPAC guidelines, let me pull those up. They have some guidelines around conversion therapy, and the way that they define it is beautiful and brilliant. I apologize for letting that one drop off of my page. Here we go. They use language that conversion therapy is attempts to compel a gender diverse person through words, actions, or both to identify with or behave in accordance with the gender associated with the sex assigned at birth. I think that that's actually a far more elegant approach than what is in our existing language in conversion therapy. Because right now it says that it's to seek to change an individual's sexual orientation or gender identity against their will. Change an individual's sexual orientation or gender identity, including efforts to change behaviors or gender expressions, or to eliminate or reduce sexual or romantic attractions or feelings towards individuals of the same gender. It does have a carve out for transgender care, but I think that actually could be strengthened along with the WPATH guidelines, which are to provide a space for especially children who begin in early puberty to have the opportunity to continue to question their gender identity with the expectation that will help them determine if they're solidifying to a gender identity or if their gender identity is different than that first one that they had looked to. Because WPATH has expanded the definition of different gender diversity. They've now included eunuchs. They've included a lot more. And I believe that those guidelines do a good job of making sure that it's not reinforcing a binary between being either male or female, transgender female, and it honors more of those differences within the whole spectrum.
Joe?
Yes, Representative Shapiro?
Yes.
Yes, Madam Chair. So it sounds like you're not really talking about changing the intent. I don't think. I don't have it.
Correct.
I don't have it in front of me. But you are talking about changing the language, and the language you just read from
WPATH.
did not include same-sex relationships or same-sex attractions. So would you include that into that definition? Is that?
Yes, I
You
would.
would
My
add that to
intention,
the definition?
my intention, if we're willing to work towards better clarifying that language, would obviously, to me, it's obvious, but would include the same-sex considerations as well. And just look to take some of this language and better clarify the conversion therapy language. Is that something that you would be willing to consider working on?
You know, yes, I'd be willing to think about that. I'd want to pull it up and see it myself and think through it. And also, as I'm sure you're aware, that this effort to ban conversion therapy, like many of the bills, like this whole bill that we're working on right now, is a product of a campaign across the country. And so, you know, I would also like to see what think about what the ramifications are for the people who have, who have really been the stakeholders who have fought for this in New Hampshire and around the country. But just offhand, you're talking about a more clear language. I'm not opposed to that, and it seems to make some sense.
Thank you. Okay, so it seems that I will query both of you as well, but just to give a little bit more of what I'm expecting that process would be, is right now we decide that yes, we'll talk about this a little bit more today. And then most likely anything that we have agreement towards language, we would then put together in an amendment form and notice that so that we could get appropriate input from those stakeholders, especially if we do get any agreement over any of how treatments are to be provided. I would really want to make sure that anybody who's providing transgender care in New Hampshire today would come and tell us if any of the proposed language that we have conflicts with the practice that they currently have in the state. So, yes.
So are you talking about taking this up with an amendment and with hearing from stakeholders within this work group, or when it comes to to our committee?
That's a good, I believe that we can have a non-germane hearing with this work group. I'd need to check with the clerk if we are in fact willing to work together of exactly how that would be noticed. But I would want to make sure that any language we have has the opportunity for good public comment, most likely in this group because we'll be closest with it, but we'd welcome our other members on the committee to sit in to see. Yes.
So personally, I'd rather see that happen within our group because I would be very hesitant to vote for any changes, anything that would change the current statute on conversion therapy without hearing from more people who that would affect more directly.
I think that sounds good to do that within our work group. Okay. And anybody else have any input? And is there anybody that's opposed to working towards clarifying the language within the existing intent of conversion therapy? Microphone.
Not opposed, but I'm just not completely convinced it's necessary. There's other parts of this bill that needs much more work or nixing.
Thank you. My thought is that if there's any place here where we can make treatment more clear and make a more clear path with less conflict, that would benefit people, especially the mental health of people who are going through this, because
But-
the more conflict that's in the media, the
Conversion therapy is not allowed, so it's not clarifying a treatment that isn't going. I mean, what's the point of clarifying a treatment that's already outlawed?
well,
Just saying.
the problem we had heard about some of the chilling impacts in a previous hearing about conversion therapy. So I'm just
That
trying to
was
get some
before it was outlawed, so.
So we have tentative agreement to look at some language. Okay, Representative Shapiro.
I would just like to be clear for myself that that doesn't include, for me, approving the language that's in this bill, which I would be completely opposed to.
I believe that we would need to work through and basically make it reflect the more clear language from the WPATH guidelines and apply that both to gender diversity and to sexual orientation. So that is my intention is for us to look at the language of conversion therapy using the more clear language provided by WPATH as opposed to the language that's in the statute in order to reduce confusion around the existing statutes for conversion therapy. And everybody who wants to do that, to try and clarify that language, looking to the WPAC guidelines, let's do a show of hands. Okay, fantastic. Then we will work to clarify that. This is not a commitment to supporting what comes out of that work, but it's a choice to look at moving forward on that. So, assuming that we are willing to look at any of the areas within the gender care, we would need to look at the definition. So I will wait to see if we're going to look at those definitions. Right now, do we have any information about whether or not if there's currently surgical gender transitions offered to minors in New Hampshire?
Not that I know of, because the age of consent is 18 years or older. And so the any of the procedures, as far as physical procedures, have to wait until the child is over 18.
What about the case where a parent consents? Still not.
I think in the state, if there is parental consent, but it also with a medical diagnosis that this is something that needs to be done. There's very few cases where young people have undergone surgery. There are some because there were medical reasons for doing them, and it was authorized by both medical professional and the parents that this was necessary care.
And was that related to the medical treatment of the gender issues, or was that medical treatment related to something else? I know that we've heard about breast reductions from girls, from people who are having back problems, and so there was a reduction in conjunction with that when the gender identity also they desired to not have their breasts.
Right.
I believe that that there had been Representative Nutter Upham. I thought you had you spoken to any of the providers to get feedback about whether or not there were surgical procedures happening in New Hampshire for minors.
I was expecting some information this morning, and I remembered that the head of Dartmouth that spoke on the day that we had the hearing said that no transgender operations of children had happened in New Hampshire under 18. Breast reduction I view as something else because, yes, it could be done because you're transitioning, but also I've had plenty of friends that were, for back problems or whatever, had reduction, but they were probably over 18. So, but I think we need to get hard facts from Dartmouth Hitchcock, which is our biggest provider, because if people are worried about 13-year-olds deciding to change their gender, I think it's probably not a valid concern if it's not happening. So that's why we need the facts on this, and I'm sorry, I'm not better prepared.
Okay. There's also the question around the fact that once you have a surgical procedure, then sometimes there's a revision that's required and then a cascade of surgeries that happens. It may not be something that a child is able to appropriately understand the consequences of that first surgery.
So that must be why very few of those, if any, are ever done below 18, the age of 18.
Representative Cushman?
Thank you, Madam Chair. So would it be appropriate for us to, since we need to find out if these are happening in New Hampshire, if this is something that we are looking into, to invite those entities to come in and talk, answer some questions about that so we can find out exactly what's happening here?
Yes, I think that even if we don't, regardless of where we want to go on this, I think that it's very important to get information from the stakeholders to know whether or not surgical gender procedures are happening to those under 18 in New Hampshire. I think that would be very, very important information for policy making both now and in the future. Representative Cannon?
Just to a side comment as we're discussing this, because I had my transition a little over a year ago. The cost associated with gender surgery procedures is outrageous. The cost of my surgery was $96,000. To do gender procedures nowadays, even in the past, WPATH requires therapists, psychologists, letters saying that they've been seeing a patient for at least a year and preferably 2 or more before they will write a letter that authorizes surgical procedures. Insurance companies also require that information before they will give an okay for them. So there are other things outside of a child and the parent want to get a surgical procedure done. There's a financial thing that's outrageously expensive. Where in the past it had been like $20,000, and that could be handled. But now we're talking $90,000 and above for simple procedures. So there's much more that's sort of financial regulating what's going on in this process too.
Thank you for that insight. That's part of the reason LASIK is so inexpensive is because it hasn't been covered by insurance. So I wonder how much the insurance covered inflation has hit those procedures. I know that until 2015, they were not covered by insurance, but under Obamacare, there was a ruling that it was discriminatory not to provide that coverage. And then it's led to both an increase in procedures and apparently a very large increase in cost. So thank you for that insight.
One more piece to add is that when people are scheduling surgical procedures in this particular area, I know at least in Boston where I went, it took me a year to get a surgery date. And I had interviews with 3 different surgeons in the process. So just to make sure that I was ready for transition, having been who I am for 25 years, they said okay, but they had to get the approvals. So
Yes, Representative Nazor.
Sorry, thank you. Since you did bring up Massachusetts, I did recently speak with a young woman. She's 27 now, but right before she was 18, she said that she skipped the whole therapy process, went right to the doctor, was put on hormones within 45 minutes. And then a few years later, if not even sooner than that, again, no therapy, went right to the doctor, had her breast removed. And so there was, in Massachusetts, I know, but so that's, I really want clarification too from some local providers about what that looks like here.
and I understand the breast reduction situation is somewhat outside. It's the genital area.
Well, and then
something like-
her story is somewhat tragic because she started things at such an early age, it destroyed her internally. So she's had all her reproductive organs removed, not from her choice. And so she's permanently sterile, and she's 27, and it's been a real challenge for her. So, just because she started hormones at such an early age that she didn't go through the puberty process. So even if you looked at her, which I welcome her to come talk to you guys. She looks like she's still 16 and she's almost 30. So she was just, her process was definitely subverted, and she paid for it with her internal reproductive organs.
Sorry, could I clarify that? So as a consequence of the puberty blockers and hormonal therapy, she had a consequence of having enough of a issue with her reproductive system that it needed to be surgically removed?
All of it.
Excuse me.
Yes.
This is a secondhand story, not from a medical professional, stating consequences that are not medically stated by a medical professional. So
I'm
I don't
happy
want-
to have her come here and talk to you.
I would prefer to hear from her
Sure.
doctor than, so I don't, we can tell emotional stories that make us for or against these kinds of hearings, but I'd like to stick to the facts, and I'd like to, if we're going to look at outlawing surgery, that's one thing. Hormonal care is another thing. Not allowing language in schools is a third thing. So let's not mix all of them up together each time, okay?
That sounds fair. The question then would be whether, I guess the biggest part is that we've heard a lot that people follow guidelines, but it sounds like, at least in the state just to our south, doctors are not following guidelines because that treatment, providing hormones with, that is not the only case that we have heard of. So it is quite possible that doctors are not following guidelines in other states. And I've heard similar from providers in other states as well. Sorry, Representative Cushman.
Thank you, Madam Chair. The New Hampshire Gender Diverse Care Coalition has a website that has like a comprehensive list of resources for people seeking gender affirming care. And they actually, I know that the guidelines, we just heard that you have to be with a therapist for a year or two, and that they have to write a letter, recommending that surgery is appropriate for you. But right at the top of this page, it says that within 1 to 2 sessions, these 7 providers in Concord and one's in Nashua, Portsmouth, a bunch of psychologists and social workers will write those letters, and it only takes 1 to 2 sessions. So it seems like it's practiced pretty regularly that you can get the letters of recommendation rather easily, at least in New Hampshire. At least that's what it's saying to the, on this website by this coalition. So it is worth probably making sure that those guidelines are being followed.
That is outside of the WPATH guidelines. So perhaps setting those baselines of good clinical practice within the laws if we have providers that are advertising for care that is outside of the WPATH guidelines might be an appropriate move. Because right now, looking at the relative groups, the WPATH seems to be pushing forward a lot further than some of the other peers. So if they advise caution, I think that we would do well to keep that caution.
Erica?
Yeah, Representative Missouri.
I do. Thank you for letting me speak. I also think it's important that, yes, we're talking about New Hampshire and what's happening here in the United States, but I would hope we're also looking around the world to see what other countries and other nations are doing right now. And I mean, I've been trying to do my research on both sides of all of it and looked to Europe, and there are several countries in Europe right now, Norway, Sweden, etc., who have put an absolute pause on all things related to minors transitioning, but especially surgery. And, I could walk you through all the information that I found, even in France and everything. I'm reading it right here. NHS also, they just kind of put a pause on all of it because of the real statistics that are starting to come out on how it's been affecting minors. So,
Representative Cannon.
I hear you, but I've also heard contradictory information because some of the studies that were used are out of date and aren't with current information. So, but I feel that that's somewhat out of the boundary here because we're looking at New Hampshire and considering this. And I guess what I want, one of the things I do want to put on the table is I think that we may be delving into too much detail that is really medical care information that, and should be handled by the medical community and not necessarily in state statute. Because it will change as people learn more about this. And as do all things in the medical profession, as new treatments and so forth come out. So if we put things in statute that impact the medical organization to taking appropriate action because we've put something in place, that may be the wrong thing to do. So, but I just want to flag that as a potential issue.
Okay, thank you. And also it's also possible to change those laws if we do put them into place as those clinical data and evidence comes available. My question now would then be about surgical gender transition procedures. And given that the guidelines say that you should spend time with full hormonal treatment, living as your preferred gender, and that prior to initiation of those hormones, there's also a multi-year process in order to make sure that that process is not short-circuited and that we are not we're not allowing surgeries to happen that then will remove people's genitals and reproductive organs in minors. Would we agree to work towards language where surgeries, reassignment surgeries, and those under 18 are not permitted in New Hampshire? Yes.
So I'm reading a letter that we got when they came to testify in March. And so occasionally babies are born with intersex or indistinguishable. So as long as there was some kind of a clause that would allow families to deal with however that gets treated, I'm not an expert on that by any means. I kind of agree that transgender surgery before 18 is inappropriate. So,
Thank you. If you look on page 6, under the 135-G2 Roman 3, it specifically allows intersex or a failure of a treatment performed elsewhere, or even failure of an illegal treatment to be dealt with. Page 6. Starting at line 12 is where it says what's not prohibited. So 15, it says that services to persons born with a medically verifiable disorder of sex development, including a person with external biological sex characteristics that are ambiguous. And so then it has some of the chromosomal anomalies and those having both ovarian or testicular tissue. Then services provided when a physician is otherwise diagnosed a disorder of sexual development, that the physician is determined through genetic or biochemical testing that the person does not have normal biological structures. And then also, beyond just the intersex issues, it does say treatment of any infection, injury, disease, or disorder that's been caused or exacerbated by a transition process, whether it was legal or not, can all be treated. So does that provide the safeguards that you'd be worried about if we were to look at the surgical procedures?
I think so. I'd like to hear from my colleagues.
Representative Shapiro?
I'm not sure we're being asked right now whether we're in agreement to talk about something, and of course, I'm always willing to talk about anything, but I don't really have an interest in including something about this in a final statute. And I'll say just a little bit more. You know, in the preamble to this bill, there's a lot of studies say this and studies say that, or there are no long-term longitudinal studies, or there are longitudinal studies that say that there's, or we have anecdotal stories. And it's not that I'm above using this kind of language, you know, evidence-based treatment, science-based treatment, studies say this, studies say that. So I think this whole bill is skewed towards saying that we have a major problem here, and I don't think we do. And I don't know the specific answer, although I just emailed to the person at Dartmouth Hitchcock about whether they'd ever provide surgeries for people under 18. I'm not sure of the answer of that, although I wouldn't be surprised either way. I can't kind of separate my feelings about working on this bill from the context of seeing this as, and I know you're trying very hard to separate it from an attack on certain people, but I'm having a hard time separating it from an attack on trans people across the country. And so I really appreciate the introduction that you gave about all the ways in which medical institutions and physicians have erred and have done real damage to people, have abused people. And I appreciate that, and I agreed with every one of those examples. I don't feel like this falls into the same category. And so I would not be in support of something that limits surgical procedures. Unless someone came here from Dartmouth Hitchcock and said, yes, we willy-nilly operate on 14-year-olds, after they've been here for 45 minutes, we agree to do that, then I would change my mind. But that's not what I heard when people came to testify at all. I heard that people, anyway.
So to clarify, are you saying that you believe that gender reassignment surgical procedures should be permitted to happen in New Hampshire to minors?
I would say that any of these kinds of treatments, were it my child, would be incredibly worrisome to me. And I'd be incredibly concerned, not just surgery, but puberty blockers or hormone treatment, whether it was my child as a minor or my child as an adult. I'd be incredibly concerned about the medical consequences. I'd be worried about them.
With all due respect, I'd love to hear your answer to her question, though.
The answer is, I think that decision should be between a parent, a child, and the doctor.
Would you be willing to place into statute that the parent, unless their parental rights have been removed, is required to be a participant in the decision around gender transition? Because you believe so strongly that a parent should be part of this discussion? That is actually within the WPATH guidelines that
The parents should be involved in the decision.
should be involved in the process, in the therapy sessions, not necessarily the one-on-one therapy sessions where the patient is speaking with an appropriately trained provider, but also having family therapy treatments, where as a family they can speak to the overall issues, speak to the benefits and risks, and the clinical sequelae. Sorry, I know as a doctor you understand specifically what I'm saying there, but basically everything that happens after you have an intervention, so that there can be a fully informed family decision as they move forward with any of the gender transition care. Or would you be willing to explore whether there's appropriate language that would honor that relationship so that those children can be in a supportive environment with parents who can work with them towards a lifelong successful life? Representative Cannon?
I think there's another aspect about this that I'm struggling with. The number of children that actually experience a gender dysphoria in our state is extremely small. The population is estimated for the entire transgender community in New Hampshire is estimated to be 0.6%. And so the number of children that are impacted is substantially less than that. And so we're getting to the point where we're going to be defining things as in statute for an incredibly small portion of the population. This would be a targeted for the transgender community. And then it comes down to, well, there are other medical procedures that are done to children with other, whether it's diseases or other situations that are defined by medical, that aren't in statute. So we're running into this thing where we're going to be putting medical care things into statute that don't exist for other procedures that may impact a similar number of children across the state. So I'm running into, are we doing the right things by putting things into statute that are going to impact a very small portion of the population?
Representative Cushman?
Thank you. So if I may, we're talking about procedures and treatments that can result in permanent sterilization, cardiovascular risk, osteoporosis, lifelong issues that will require lifelong treatment to deal with. And we're talking about anywhere between the research that I've looked at, 10 and 30% desistance rate after these treatments and surgeries. And though it's a small number of the children and of the entire state of New Hampshire, we're talking about very, very serious sequelae and a very kind of new, a new and exploding rather fast area of medicine. And as these guidelines are formed, I think it's appropriate for us to, we're not, whenever there's a new technology or new innovation, many times there's discussion about moratorium, to wait and see. And, we need to understand what's actually happening. And as far as legislating medical practice, when there is this much risk involved and the fact that a child may regret it and have lifelong sequelae, medical sequelae as a result, we're talking serious trauma. I think that it's a very appropriate place for the state to step in. We require a specific consent form for a woman to have a vaginal birth after a cesarean. So this isn't outside of the wheelhouse of what the New Hampshire legislature has done when it comes to procedures that could potentially be very risky.
Thank you. Representative Mazur?
Yes, thank you. I just want to speak back to something that Representative Shapiro said, that when you talk about things like this being, and I've heard this before, an attack against a certain community, I do think we have to be careful about that, because that's not how I do my life. I don't go around attacking certain groups of people. This is specific to minors. So personally, as an adult, what you do is your business. Live your life the way you want to do it. I have many friends in this community, and they are doing that. But we are talking about minors. So that's the differentiation between this being an attack on a certain community, this broad community, when many of us are just right now wanting to just step up and say, you know what? This is for the kids. Let's let them be kids for a little while longer until they're adults, and then can make that decision. So
Thank you. I'm actually going to refer to some of what you brought up, Representative Shapiro, and then I'll recognize you after. My motivation in pursuing this isn't to demonize any group or cause any trouble for any groups. I, as a medical device analyst, worked with many emerging therapies. When we had drug-eluting stents, which are for, they're actually not to prevent another heart attack. It opens up the blood vessels, but it makes it so you're not having that chest pain that feels like a heart attack. They came out with drug-eluting stents. So those had paclitaxel or docetaxel on them, and they started flaking off and killing people. So that was an adoption where all of the clinical data, all of the clinical evidence showed that there was going to be a benefit, and it seemed to be a minor risk. It was broadly adopted, and many, many people died. So many that one pathologist had so many patients through that she was able to find the parts that had flaked off and were found in people's brains. As somebody who has been involved in medical technology and medical advances for a large part of my career, understand that when we're in an early adoption phase, there's risks that are not known. And my motivation in actually coming together and trying to figure out where we can draw some good hard lines right now is to protect children who may not understand the way that new medical findings end up changing over time, and also may not understand just how lasting an impact those procedures can have. Quite frankly, I think that if we can at least set some minimum guardrails around this, like preventing this surgical gender reassignment procedures in minors, we're going to have a lot less discussion on this. And so there will be less of this conversation where people will incorrectly feel attacked by people who are doing this out of a motivation to make sure that basically that there's time to pause and think before you undertake a procedure that has been done predominantly in an adult sexually mature population, and that when you translate a surgery that's been done in an adult sexually mature population to children, to minors who have been did not go through normal puberty and did not go through the normal physiological processes of that and have been on other endogenous drugs, that there are risks that we will not know until after these children grow up and we're able to see what happened. Right now, you're looking to evidence in adults and then extrapolating that to children. In any other field of medicine, children are not small adults. Even adolescents, even young adults in some areas have an entirely different treatment protocol than mature adults. So there are different guidelines in some specialty areas that are under 16 and then 16 to 25 because physiologically they are not the same as an adult. We know longer term data on adults with these therapies. We do not know them with children. And to take the most extreme part of this, which is the gender reassignment surgeries in minors, off of the table, I think that there'll be a lot less of this discussion of this, and it'll bring a little bit more peace, a little bit more understanding, and we can start talking about how we're trying to make sure that they aren't early adopters that are harmed. So, Representative Shapiro.
Thank you. I would apologize for extrapolating my view of the national situation, extrapolating that to the people in this room, and I apologize for attributing motives to the people in this room.
Thank you.
To go back to the earlier question about parental consent for gender-affirming care in general or for surgeries, I've learned a long time ago that HIPAA and consent are so complicated that every time you think you have it right, you don't have it right. But my sense, as someone who's been in related professions, is that a minor getting gender-affirming care or any other care who is going to have a medical procedure, a surgical procedure, would need parental consent, meaning to be included in decision-making, and consent to actually have it be done. So my belief is that is already being done at the one place in New Hampshire where this kind of care is offered. If I was to find out that it was a problem, that it wasn't happening, then I would be open to the idea of including that in statute in some way. I think it's already covered, but if I found out it wasn't covered, I would agree to that, because I feel like 14-year-olds, 17-year-olds shouldn't be having these kinds of surgeries without the agreement of their physician, the medical team, their family, being included in making that decision together.
Thank you, Representative Cushman.
Thank you, Madam Chair. On all of this discussion, what keeps popping back into my mind is there are currently guidelines, and so we have some guidelines of the most forward and most well-researching organizations. It's a global organization that they've set forth, and it includes the consent piece, it includes the surgery piece, it includes, hormones and, kind of eliminating extraneous variables like depression and treading carefully with children with autism spectrum disorder. So we have the guidelines, and this is a new and rapidly expanding area of medicine, and we're wanting to put these guardrails in place. So I would say that it's more appropriate to put the guidelines in place and then, or at least propose them. And then if there's something in the specific guidelines that we propose that does interfere with current practice by these organizations, then they can then, or by, any of the clinics, and they don't agree with it, then they will have the opportunity to show us exactly where and why. And that will help us in sorting out the fine details of those guidelines.
Thank you. I have another statement, then I'll toss it back over to you, Representative Shapiro. You had also mentioned when you were speaking about the opportunity to be involved when those earlier decisions happen as well. And in those guidelines, it does say that for hormonal treatment, it's important to have parental involvement too. The question, it sounds that Representative Shapiro, that you believe that at the point of surgery, the parent needs to be part of that consent process. How much earlier and with what kind of side effects do you think that the parent should be involved in the consent process when one of the known risks may be lifelong fertility issues, increased cardiac events, and then especially increased depression? Because some of these therapies, especially some of the hormonal therapies, have increased depression. And if a parent is in the dark, they may not understand that their child is now, because of their medication, more likely to undergo a significant depressive event that could have life-ending consequences. When do you think that the parent should be part of that process, or at least informed?
When my niece, who's 38 now, was a young child, she was incredibly short, and she just wasn't growing. And so the doctors suggested a puberty blocker, so she would have time to be a more normal height. She didn't have a genetic problem that seemed to be causing her to be short. She's still really short. So she was put on a puberty blocker for, I have no memory of how long it was, to see if she would grow a little bit more. She did grow a little bit more, but not very much. And her parents were, there's no way that would have been done without her parents' involvement and consent. Really, probably they made the decision. I'm sure they consulted with her. But so I would think that any kind of medical care, other than the ones that are already kind of separated for privacy reasons, like STDs and substance misuse care, where it's been judged a long time ago that it would be better to allow people to access this in privacy. Any other care, I think, should involve parental consent and parental involvement.
Thank you. We may have found a point of agreement. And if we can find agreement out of this, I think we're going to have a huge win. Because you brought up the precocious puberty, I think that that's actually an important part. I have some information to share with us on that.
Can
Yes, Representative Shapiro.
I just want to make one other comment that's a little bit separate from, I was wondering if Representative Cushman was suggesting that we embed these protocols or these guidelines into statute. And I would wonder if we ever thought about doing that, what would be the repercussions of every time they change their guidelines? You have to change the law, or how we would even do that. That's a separate issue.
Okay. So we can take up that separate issue in a moment. So treatment of central precocious puberty, which is when you're going through puberty early, usually is done for height reasons, because if you develop puberty too soon, then you stop developing with height. And so it is the central precocious puberty. It occurs in 5,000 to 10,000 children, mostly among girls. And mostly on girls, it's idiopathic. They don't know why it happened. So normally when that's done, it can be initiated as young as 6, and then it can be initiated. It's almost always initiated before Tanner stage 2. And then it is ended. They don't really know exactly when to end it. But there's not really any data that shows that going past the bone age of 12 or 13 shows any benefit. So for the most part, it appears that clinical practice ends the hormone, the puberty blocking drugs before the time that many children are going through Tanner stage 2, which is when puberty blocking drugs are indicated for gender-related issues, which actually really brings into question how relying on the long-term safety and the long-term consequences of puberty blockers in central precocious puberty relates to the use of puberty blockers in gender issues. So that's just yet one another area where we're trying to do the best we can with the science we have, but we need to make sure that it's not oversold to these families, because this is hard for us, and many of us have medical backgrounds. Can you imagine a parent when it just suddenly there's something that's a surprise?
You'd have to find someone a lot smarter than me to respond to that distinction.
So if we can go back to this idea of embedding some of the guidelines in, I think that if we can perhaps find a floor of what needs to be practiced in New Hampshire, that we could look to some of those guidelines. We have many places where the statutes do refer to guidelines or to different protocols. In administrative roles, we have even more of those, and those typically are updated every 10 years. There are a few places where in law or in statute we refer to sort of an evergreen link to guidelines and protocols. But that is very rare, especially because you don't know which direction it's going to take, and there may be a need to change it before then. In some of our building codes, we purposefully hold back on a new edition of the building codes because the changes are more beneficial to other regions than they are to New Hampshire. So the idea of referring to a specific area makes sense. Looking at the guidelines, it's more of an informational guideline where there's the principles within the Standard of Care 8 from WPATH. And they basically have it where you would, where if as a lawmaker were to implement it, some of it needs to be tuned to your area because some places are using ICD-11, some aren't. But having those principles about which medical providers are able to provide care actually, I think would be very beneficial for everybody because WPATH requires that they have specific training and specific ongoing training in gender issues and in diagnoses of other mental in diagnoses of mental illnesses which may have an impact or may present similarly, so that those can be ruled out, so that you make sure that you are actually treating true gender dysphoria, gender diversity, as opposed to mistreating an illness or mistreating something that that actually needs to be treated in a different way. So if we're willing to look at these, we can take a few minutes and I can pull together some of the language that we could pull directly from from WPATH guidelines in order to set some requirements around that. Do we think that there should be a level at which somebody needs to be trained in order to provide medical care for transgender or gender questioning or gender diverse individuals? Representative Naderopen?
Yes, but I have no idea of what. I mean, who would be our guiding person to do, what medical association or whatever would decide what level of expertise, what kind of training would that's a very difficult question.
So if there was a clear-cut set of definitions that we could look to an outside agency, perhaps Representative Cannon?
I think that might be an appropriate question to ask someone from Dartmouth. Is how do they judge that somebody's at a level that they can provide services? I do know in my own speaking to audiences about that the things that they should be looking for, the feedback was, well, we don't feel qualified to provide that service. So in some ways, they're self-policing themselves, saying, I'm not going to take a patient because I don't know how to care for them. And so that's a good thing. But then there are others that have established practices that for some reason, whether it's an organization or are deemed that they have the knowledge and the ability to provide that service. So that might be a question for our friends at Dartmouth.
Okay. I think that might be a great question to find out from them, if we could have them here in a follow-up meeting. So would we be willing to look so with that, we'll take a look and try and see if we can get some basic language that we can ask them about to be able to present and say, this is what we have from these guidelines, make sure that it's available ahead of time. And if there's a different competing organization that is more suited to determine who can provide medical care and medical counseling, that would be the next steps. Part of the concern is, were there any more comments on that, Representative Shapiro?
I think hearing from people who are intimately involved in this kind of care would be a good way to go about that. But are there any other similar guidelines in statute about like what specific care beyond, what specific certifications or what specific experience or training that medical providers have to have beyond the fact that they are thoracic surgeons, say, to do a certain kind of surgery? Are there other examples of this in statute, is my question.
There are many examples in statute of different professionals who need to have certain certifications in order to practice in a certain area. I believe that is also the case in medical professionals. That's why we have so many different areas and different sections of licensure. But I know for a fact that in other areas where we're not talking about the integrity of a person's body, we absolutely do have those specific certifications in many other fields.
That are separate from the parts of statute that list the scope of practice? I mean, are there certain like diagnostic groupings that are then like, there's not being very articulate, are there certain diagnoses that are referred to in statute, and who can provide care for those diagnoses in terms of their training, their experience, their certifications?
If you look at that's part of why we have a breakdown of some of the different medical specialties. The question is how granular, and in an area of an increased emerging area of therapy, making sure that only those people who are qualified to provide good health care would be beneficial to this, to especially a community that feels that the world is against them, to make sure that only those healthcare providers that truly do know the best science would be, I think, one of the most beneficial things that we could do.
Perhaps you could refer me to like a specific example involving some other kind of care that this would be parallel to.
I'll see if there's anything that's parallel to that.
I have a quick question.
Representative Mazur?
Yeah, just a quick question. So as of right now, Dartmouth is what I've been hearing. They are most likely not performing transition surgeries on minors, as far as we know, right? So my question is regarding statute, if them and no one else is, why?
Why are we?
Why
hearing
are
this?
why aren't other providers doing this? Are they allowed or are they not allowed? Like, do we have a statute in place right now that prohibits them? So then why aren't they doing it?
It's sort of managed within the medical field, within the, it's like there are only certain centers in the country that have transgender health units. Dartmouth is one.
Right.
Down in Mass General and a number of
Yes, I know
hospitals.
about, yeah, I know about Mass.
So
yeah.
those have staff that are trained
Right.
specifically for transgender health.
So it sounds like Dartmouth does. And, yeah, I'd really like to know if this is happening there then. I'd like to know that sooner than later.
Representative Shapiro?
Probably doesn't shed very much light on the situation, but I just got an email from Courtney Tanner, who's one of the legislative liaisons for Dartmouth Hitchcock. And I asked her, are surgical procedures related to transition done at Dartmouth Hitchcock on minors, even if infrequently? And she wrote, as a rule, no. Like any practice area, there may be very rare exceptions.
So, okay, that actually seems even a little bit more concerning to me.
It does.
Because that one of the biggest areas is there's a lot of areas where you're not able to practice certain surgeries unless you have a certain volume, and even within different subgroups of patients. But I'm glad we have that information. That gets us a lot closer. And then for more follow-up from Dartmouth, I would like to know what those exceptions are, because we want to make sure that nobody is denied appropriate care, but we also want to make sure that people are protected, and especially children. Representative Cushman?
Thank you, Madam Chair. It's my understanding, so from that same website I was talking about earlier, there's also a list of surgeons, and two of them do surgeries at Dartmouth Hitchcock, but there's a third that does them at Elliott. And then as far as hormones, Planned Parenthood of Manchester, there's an MD in Portsmouth, the Levering Health Center in Greenland, Affirm Endocrinology in Lebanon, Amiskey Health in Manchester, Goodwin Community Health in Somersworth, and Equality Health Center in Concord, as well as the UNH Health and Wellness Center. They also, they're also offering these services. So we invite them to give us feedback on whatever it is that we put forward as the baseline guidelines for this. Or I would like to, Madam Chair. And I'm just considering, if they are not doing these surgeries on minors, then there should be no pushback of having that in statute. And if there does become a pressing need and the evidence comes to show that it is much beneficial, contrary to what the evidence is showing now, we can bring that back they could bring a bill to change that later. Just going back to the concern about putting guidelines in statute.
Thank you. That's very helpful to know who is providing surgical procedures in New Hampshire.
That list was 2 hospitals, surgical procedures, and all the other one were hormonal.
Hormonal.
Yeah, I
yes.
just wanted to make that clear.
Thank you.
Because somebody listening in might think, oh, all of those places are doing surgery? They're not.
Thank you for that clarification. So the safeguards for the gender-affirming medical and surgical treatments according to WPATH are that the healthcare professionals assessing transgender and gender diverse adults for physical treatment shall be licensed by their statutory body and hold at minimum a master's degree or equivalent training in a field relevant to this role and granted by a nationally accredited statutory institution. Able to identify coexisting mental health or other psychosocial concerns and distinguish these from gender dysphoria, incongruence, and diversity. Able to assess capacity to consent for treatment, have experience or be qualified to assess clinical aspects of gender dysphoria, gender incongruence, and gender diversity, undergo continuing education in healthcare related to gender dysphoria, gender incongruence, and gender diversity, and healthcare professionals assessing transgender and gender diverse adults seeking gender affirming treatment shall consult with professionals from different disciplines within the field of transgender health for consultation or referral as needed. I think that one of the biggest areas that we do need to perhaps exercise some caution is that some of what we're hearing from the schools, it sounds like they're actually conducting medicine without a license with some of the counseling that is happening from teachers and others within, because we are hearing statements by some people who are on school boards that basically say that that the people in the schools are those who are best prepared to speak with children around sexuality and transgender issues. And having those discussions, especially within this whole context about being able to identify, basically identify all the issues around it, that by giving free rein to have discussions about these topics in school, and especially one-on-one discussions, that this is actually quite possible that somebody may be providing false information, misleading information, or dangerous information when what they should be doing is referring any of these students with concerns to an appropriate health professional who has the appropriate training. So this is one of the areas where I think the fact that we have some reference to the schools is quite important. So we actually, we have Representative Prudhomme O'Brien actually has some information about some of the statements that some school board members have made about the appropriateness about whether children should be speaking to their parents or should be speaking to people in the schools with their questions around gender issues. I'm not sure if you want us to speak a little bit more amongst ourselves, or if this is something that you either wanted to send me the information so I can read the statement that was made, or if you'd like to share with us. Yes, because I'm very worried about the potential practice of medicine within the schools when that really should be happening with appropriately trained medical providers. And well, okay. When you do have that, then we'll need you to put the light on. So I'm sorry if I shifted gears a little bit quickly on all of us there. It just seemed very relevant to the issue of healthcare professionals being appropriately trained. Is there any pushback on the idea of making sure that people are speaking to competent providers?
I didn't hear the question.
Oh, just, I'm going to assume that nobody has a problem with making sure that people are speaking to competent medical providers when they have questions. So.
Just lost it. I thank you for having me. I'm Representative Prudhomme O'Brien from Derry. I wanted to be certain that I was very accurate in what I say. A few weeks ago, someone sent this to me because they were worried about it. And I read about that. This school board member thinks that there should be experts from outside of the community to come in and speak to students about gender issues because they think it is not acceptable for any parent to impose their religious beliefs and personal ignorance and dictate the education of everyone else. I think that this is a personal issue that parents do have the right to speak to their children about. Then the school board member goes on to talk about generational differences, and that's an age issue. So if parents are older than, I don't know, 40 or something, that doesn't change the fact that they care about their children and they have the right to talk to their children about their deeply held beliefs. I think that if parents can talk to their children about religion, this is just as personal and important to parents. And I think that's
Thank you.
what I have to add.
That's really helpful. So in the reading, it sounded like they were saying that the parents should not be involved in these discussions with their children, but to leave it to the schools.
And that parents of the older generations are not equipped to do so. So I don't think that is accurate. I think parents know their children. Parents love their children. The overwhelming majority of parents love their children very much and want what is best for their children. And, is there a question? I mean, does anybody know?
Thank you.
I just wanted to clarify, so someone on the school board thought that parents should not talk to their children about specific subjects?
That they need help because of their ignorance and religious
Okay.
beliefs and things like
I
that.
think we have to worry where our society's going if we're beginning to dictate through laws what parents can talk to their children about. Don't you?
Yeah, I think that parents are equipped. And even
Well,
if parents,
even if parents aren't so equipped, they're the parents.
I agree with you completely, yes. And when parents do find an issue with their children that is new to them, they become equipped. I mean, as a parent, anything. When I became a parent, the first thing I did was learned all about breastfeeding, for example.
Yeah.
That thing.
No, thank you.
know?
I think we've actually may have found a point of agreement, the fact that we need to make sure that parents are not cut out of these discussions. Is that something we can all agree on?
I'm 73 and I think I should have the right to talk to my kids about.
Yes.
Although I have to be very careful to tell you the truth sometimes around certain issues, but
Good.
I think parents should always.
Bravo.
I mean, parents should always be encouraged to engage their children about all issues.
Thank you. Representative Cushman?
Thank you. And then in that vein, and coming from that same testimony that you provided, a parent has more stake in discussing these things with their kids than a teacher who's not trained on this. So that's where the rub is, I think, to insinuate that a teacher who has no formal training on this and is not a medical professional has more of an ability and a right to discuss these complex medical issues with a child and a parent. So it really speaks to both requiring the competency and ensuring the parent involvement.
Thank you very much. I agree with that. And my feeling on that is the same as yours, but even further, I think that even teachers, I applaud teachers and the work that they do, but even the best ones are mere visitors for a short period of time in our children's lives. The parents are there for the long haul. The parents have been there for the long haul. They have watched their children over a long period of time. And they will be there when the children have problems in the future. And that's the difference. That's a big difference. I myself got a lot of help from some wonderful teachers when I was growing up, and social workers. And I love them. I think of them as, the very heroic figures in my life. But sometimes I would stop and think when I was a teenager about them that they were paid to be there. They were paid to be there. That was a little different. That was just a different perspective than parents have.
Thank you. This has been very, very helpful. I really appreciate you bringing this so that we can understand some of those perspectives from outside. Representative Cannon?
Thank you. Thank you for your comments. Greatly appreciated. I had both of my daughters struggled in school with depression and anxiety, and it was brought to our attention by the school that we might want to seek out a therapeutic care for someone to investigate why. And just like in all procedures is what went on with the therapist that we finally got. It was like Las Vegas. Whatever went on there stayed there. But the kids went back for multiple sessions and they were fine.
And you knew, and you had the ability to help your children because you were informed. That's very important.
To a point.
Yeah.
Some of what was discussed in those things was between the child and the therapist, not with us directly.
But you were able to address it like a responsible parent because you
yeah.
had the information. And
Right.
That's,
And that was,
I think we get to that later.
And I think if we can equip our schools with the knowledge that if a teacher encounters a child that's experiencing a gender dysphoric type situation, is that it's above their pay grade, so they should be referring it to somebody else who can help.
Thank you.
Maybe we can get something really good out of this. Thank you. Representative Mazur?
Similar testimony just happened at our school board meeting recently where a paraprofessional, and she spoke as a paraprofessional at a Manchester charter school. She did not come speaking as a private citizen, which she later said she did, but she didn't. It's on video. She spoke as a paraprofessional in a Manchester charter school, and she sat right at a table like that and said, I am this, and I work at a charter school in Manchester, and we are teaching gender identity and sexuality information to kindergartners. It is being done. That was her exact same words. And then wondered the next day why her school wasn't under investigation. Because when parents hear about this stuff, it's rightfully so, you're going to be concerned, like, wait a minute, I didn't know that was happening. But then, then came up to the table a few weeks later and was appalled at that her school's now under investigation for that on a private school board video. So that's why it is so important now that parents are involved. And we have an RSA in place that makes it legally requires schools to give parents notification 2 weeks before anything like this is either put on a whiteboard or taught in schools or anything. Like, parents have to be involved. That's all we're saying, is to keep parents in it.
To that point, the Department of Education recently put out a memorandum on that specific issue. It's on the New Hampshire Department of Education website. Frank Edelblut wrote a memo regarding that to inform parents that had questions about that and wanted more information. So I want to mention that for anyone watching.
Yeah, thank you.
Yeah.
Thank you. Thank you. That was very helpful. Thanks for bringing that insight to us.
you.
I'm seeing that we have a little bit less agreement around the preventing surgical transition procedures for minors than I was hoping we would have. But I think that may be something that we should try and work forward with in a future meeting to try and get more information from Dartmouth and from any other providers so we can understand what's happening. I think we all have... was it a correct read that we all have an understanding that that teachers and others within the school that are not appropriately trained shouldn't be counseling students on this, but instead should refer them to an appropriately qualified medical professional?
Representative Leon.
Yes,
Can I
okay.
just, point of clarity, are we sure that we're, can we?
Maybe.
Yeah. Can
So
we re-ask the question maybe of, are we all in agreement that transition surgery for minors under 18 should not be a thing?
Yeah, let me get through this other question around the around teachers and the discussion. There's definitely an importance to make sure that anybody who's discussing this is well trained, aware of the recent evidence, and is keeping up with all of the advancements in this dynamic field. Do we have agreement that teachers and other school professionals should not be counseling students on these issues, but rather making a referral and notifying the parent unless there is a reason under existing statutes to exclude the parent from that notification through any of the DCYF type processes? Representative Shapiro?
Yes, I'm not sure that, I'm not clear what I know we're just making an agreement to talk about it, but I'm not clear about exactly what we're making an agreement to talk about like counseling or curriculum or talking about gender at all. I think this is a slippery slope. And I think we have to understand the
So the question I was asking here,
the complications. So for example, you know, my granddaughter has two mothers, right? So some people might feel it's damaging to, in the course of talking to an elementary school class, to refer to families that have two same-sex parents. I don't begrudge them that. They would feel very offended that their child is being exposed to that. Well, it would be damaging to my grandchild to not be exposed to that in school. So I think, I'm not sure if we're talking about clinical treatment when we're talking about like that the school shouldn't be doing clinical treatment, or what they should be talking about in the course of, you know, developing curriculum or just general conversation in the school. But I think in some states, there have been very rigorous and I think harmful laws passed about what can be talked about in school and what cannot be talked about in school. And so I would certainly not be in favor of being on that,
so
being involved in that.
I had asked the question about counseling. So when somebody comes and says that I'm not sure about my gender, that then would become counseling. If you're discussing intimate topics like that, it would be a separate discussion about the sexuality and discussion of that in classroom type situations. But right now I'm talking about when a student comes and says, I'm not comfortable with who I am. I think that I'm somebody else. Is a teacher equipped to provide the counseling that would then be required? And does that rise to the level of having an appropriately trained medical professional? Representative Cannon?
I would agree with you that there needs to be a referral to someone that knows what they're talking about. My concern would be if there's a referral, are we outing a child by referring them for gender help, or is there a way for a recommendation to seek therapeutic help and let the therapist decide if they need to refer them to another specialist? Because the challenge is in outing a child is where damage could occur, especially if a parent doesn't want to hear it.
And thank you. That's definitely one point. Also do have a counterpoint, though, that there is the concern that when a child is undergoing something that is this big and this complex, if their parent doesn't understand that there's something going on, not even giving the opportunity for a supported discussion to happen with the parent, the child may be so concerned about this that they're not able to confide in a parent who would be supportive. And even a parent who may be hesitant won't know to look for the signs of a potential imminent catastrophe. And that harm in keeping the parent out of the loop could also have severe consequences. Representative Cannon?
Just a continuation, using the example of my daughters, I have no idea why they went in to talk to a professional for their anxiety situation. And they still, at this point, when they're 40 and 36 years old, still won't discuss those discussions that went on with the therapist. So we as parents never knew and still don't know what was the problem. The good news is they resolved it. And it didn't require our assistance, which may not be the case. It's in a transgender child's situation. However, for a school or someone in the school to come to a parent and say, we think that your child needs to see someone who's knowledgeable about gender dysphoria and those things could potentially be a problem for a child who's already struggling themselves, and as we've seen, is where a child will take their own life because they now don't feel they're getting the proper attention at home.
Representative Nanarupam?
I think the point that you're trying to make is that teachers who are not trained in counseling should not be counseling.
Correct.
And I would agree with that. Just, there's lots of well-meaning people that have had some personal experiences themselves that they think, well, I can help them. But you're right, it's above their pay grade. And as Jerry said, referral. So, and I'm sure teachers are very good at getting close to kids and then realizing, well, child will tell them something and they need to refer them to school guidance counselor or law enforcement or, whatever it is, because they're mandated reporters. And anyway, yeah.
Okay. Representative Cushman?
Yeah, I have to agree with you that, and to your concern, I think as long as, it's a referral for counseling, they should include the parent, but if there's some concern, at least it's a professional who's talking to the child about it. And they might not name the issue, they just might say, we want to refer your child for counseling because they're showing some anxiety issues or something, and it's beyond our scope of, authority and knowledge. So we're going to refer.
Right.
I think we may actually have some areas where we have some agreement. I know that I need to use the facilities. I don't know if we can just take 15 minutes, or do we want to take 15 minutes, or do we want to take half an hour and then come back? It's 12:30.
I have no food. I'm not going to make my 1:00, whatever, so
Okay.
whatever.
So we'll just take 15 minutes for the restroom. Maybe if we wanted to just consolidate some thoughts amongst our separate groups and just consolidate some thoughts and figure out our next steps.
Yeah.
Okay, thank you. So we'll take a recess for 15 minutes until 12:45. Well, thank you, everybody, and welcome back to the work session on House Bill 619. As far as the guidelines and all the other information, there are guidelines on the WPATH website. It's the SOC 8. I can email that to everybody on the subcommittee. And there's also the Endocrine Society guidelines, since they've been dealing with hormones and those treatments for a long time. I think that that would be helpful for us also to review. There are some other societies as well, if anybody wants to share it, but I figure I'd be happy to look at any as we work on our work going forward. I'm really happy and really impressed with all the areas where we found agreement today. I think that it shows how much we're all looking to try and work together and try and find the right solutions and get past this whole top level controversy, and actually look at the best well-being of these children. So I actually am going to see if Representative Cushman can sort of summarize where we are, and figure that out from there. So, Representative Cushman.
Sure. Thank you, Madam Chair. So we had some agreement on setting some guidelines for the actual medical care, pulling from the national organizations who have done the most forward research on this. We also came to some agreement about ensuring that there's parental participation as much as possible. And we've discussed redefining conversion therapy. And we've also discussed agreement on establishing that the appropriate medical professionals are providing counseling on this to minors and not those who are not trained. I believe that's everything. And as next steps,
And just with that, yes, I think that is everything. And I do want to clarify on the conversion therapy. Would be going to language that is more clear about not coercing anybody, so that we can make sure that the language doesn't cause fear and confusion and a resistance to therapy. Because right now, I think there's a lot of confusion about how that's interpreted. So we would not be looking to change the intent or change the purpose of the conversion therapy ban. It would be simply to clarify it so that we don't have people who are worried and that is causing controversy and making this hit the news media, because it's not good for anybody to have this fight continuing to play out in the news media. So next steps.
so as far as next steps, I see us bringing a draft forward and then having that available for all of the entities in New Hampshire that it may impact, and giving them an opportunity, if their practice deviates from the best practice guidelines, that we would like to also put in statute that they bring us their policies and procedures and tell us where exactly it deviates and what the evidence for that is and what their outcomes have been. And that will give us an opportunity, if there are myths, we can dispel them here in the committee. That will help reduce that high level controversy that we're seeing in our communities right now. That, some of these more egregious things that may be happening in other countries or in other states that are not happening here, let's get that on record. And if they're not happening here, then the guidelines will be in place to make sure they won't happen here in the future. So that's what I see as our next steps.
Do those general conceptual areas work for our next steps? Or are there concerns on those? And we can summarize that and put that in writing so that we can know our next steps and have that written in an email. We aren't going to have discussion outside of the subcommittee, but if there were any errors in what I do send out to everybody as those next steps, let me know, and then I can fix those. If that's based off of this conversation, that's just a correction. Representative Shapiro?
So just to clarify, the next step would be to have another session of this committee and to invite some people who are involved in providing care to participate in that?
Yes, we would specifically be looking for testimony from those who provide care or whose organizations provide care with specific feedback on language that we can then provide to them as we draft different sections of this so that they can know what we're going to be discussing at that point. And anybody who's interested in any of that language or any of that information can email me and I can send that out. My information is on the State House webpage. Just so that we can make sure that we do this as a committee. We already heard about the overall topics, and we don't need to have another overall hearing situation because we already know all of the people who are brave enough to come and speak in public about the general topics. What we need to do now is talk about what we can do so that we can stop having to have those big, larger conversations that may not be as productive just as a whole society, and work on focusing on those areas of agreement to make sure that we understand where care is in New Hampshire, what guidelines, if any, we put into our statutes to make sure that everybody on both sides feels comfortable about where the state of transgender and gender diverse care is in New Hampshire. Sorry. Representative Shapiro?
So I would just like to clarify for myself that these 4 areas, medical care guidelines, parent involvement, appropriate medical, having appropriate training to provide certain types of treatment. I think we were talking about counseling mostly. Redefining, using different language to define conversion therapy. I think I just want to speak for myself that, for example, in terms of parental involvement, no, in terms of the example that we were talking about before we left, that if a child brings up some distress about their gender or questions their gender, that the teacher shouldn't take that on as their own counseling project, that there should be a process in schools for referral and to a trained professional, a competent professional. Mm-hmm. Sometimes they're different, trained and competent. So I'm in complete agreement with that, but I just want to be clear that that doesn't mean I'm in agreement with that. I think that this should be in statute, and that we should proceed to find wording to amend this bill about that. So there's agreement about the basic concept, but I don't agree that this is something that we should be taking up in this committee or as a legislature.
Thank you for that opinion. If we can get to where at least you agree on what the words would be if they were to be in law, at least then we can get it to that point about whether or not it deserves to be in law.
Very willing
Because
to talk about it, but I just want to be clear what I'm agreeing to.
That makes sense, and thanks for helping us set our expectations so that nobody's opinions are misconstrued.
Just a quick comment on that. Having been on a school board and dealing with school policies, the challenge for us, we can put something in statute, but the school system may take that and do what they feel like in addition to. So that's a problem area just in general, no matter what we say here in the legislature. To put on the school is that policies can be written locally, that get implemented locally. And that's always been a problem, a challenge, because even the New Hampshire School Board Association only provides a draft for schools to use, and then they change it based on their local needs.
Thank you. That's great input from a former school board member. So thank you very much. Representative Mazur?
Yeah, thank you. I agree. And it is oftentimes too that, and I've watched it because I've been to a lot of school board meetings lately, is because there's nothing in place. It just there's this big limbo land that they're in, and it actually causes more division when there's nothing to fall back on that says, hey, they need to do this. and that's it. Because when it's just a kind of a free for all, which I've been again to a lot of meetings lately, and it's been a challenge of them not even knowing what is in place and what's not regarding things. So I think the better that we can do about putting something just to for them to look at and refer to would be really helpful.
Thank you. I think that these are great next steps. I know that we all have complex schedules, so I will query everybody offline so that I can again assemble my spreadsheet and see where we can fit our meeting, where that will all be available. I appreciate you all taking the time and really being willing to dig into this.
What is the deadline for us to vote to recommend something to our committee?
We would need to vote to recommend something prior to when we meet an executive session to vote on the bills. All of the bills need to be dealt with by the 17th of November, which is effectively the 16th. I think the sooner that we're able to address this, I think the better. But we do still have a couple weeks within here.
And I think our chairman was it only yesterday? Or was it the day before?
I think it was Tuesday. So,
Both
right.
days I've been here.
Uh-huh.
Was going to maybe try and schedule our executive session for November 6th.
There was some discussion about either the 6th or the 13th.
Okay, the
it-
13th would give us a little more wiggle room.
That-
Constraints that week.
Okay. And with that, it would be helpful to know sort of your general constraints through probably the 13th or 14th so that I can then also help the chairman know when we'll be able to slot in our executive session for all of our work. So that would be very helpful. So fantastic. Thank you very much. I appreciate all of you and I appreciate the opportunity to actually get into the depth and importance of this subject.
Thank you.
Thank you.
Thank you.